Okay, let's start with the case. You're in clinic and Mum brings in a 9-year-old boy because he's limping. He's been a bit hot. He's generally pretty well, has had some school sores and a couple of sore throats. You try to get him to walk, but he's not too keen. What's our differential? Irritable hip, Perthes, septic arthritis, or perhaps osteomyelitis? What if I tell you that this is how you got to work today? We're in remote northern Australia and this boy is Indigenous. Does that add anything to our differential? I'm Mel Thompson. I'm a paediatrician in the Kimberley and I'd like to talk with you about one disease that should be on your radar. Let's talk acute rheumatic fever. If you're new to Northern Australia and your workplace looks more like this than this talk is for you. If you live in the city, you might see these patients when they're transferred for surgery or at boarding school. And if you just like interesting medicine or support equity in healthcare, the rheumatic fever's right up your alley. A US government website describes rheumatic fever as a disease of developing nations, but it exists right here. This is my collation of publicly available reports, so not the final numbers for 2012. There's been a huge rise in reported cases in Western Australia from 6 in 2008 to 54 in 2012, with at least 35 from the Kimberley, which has a population about the size of Wagga Wagga. Now, there is detection and reporting factors at play here, but we do seem to be having a genuine spike in the numbers. These high rates are not new news. Around the world, acute rheumatic fever is a disease of displaced and poor populations. Australia has the highest rates in the world, streets ahead of our neighbours, New Zealand. So congratulations, Australia. We're leading the world. But this isn't a record I'm proud of, and it's why we all need to recognise rheumatic fever when it happens. In 1944, Dr. T. Duckett Jones outlined his criteria to diagnose acute rheumatic fever. He lends his name to a nice little mnemonic: Jones, joints, nodules, erythema marginatum, and Sydenham's career. What about the heart, you say? Well, that fits in here. Let's go through these. Joints, or arthritis, is often what kids come in with. This picture shows quite well what these kids look like. They're miserable, hot, their legs too painful to walk. Look for inflamed joints, often knees and ankles, with a typical migratory pattern. In high-risk populations, this includes the ever-challenging monoarthritis. Look for a septic joint, but don't forget rheumatic fever. Carditis is what kills. I've seen 2 primary school students in the last few months with severe mitral regurgitation needing urgent valve replacements. Listen for the murmur or a rub, feel for a large heart, and check for signs of failure. If everything seems normal, don't discount rheumatic fever, as cardiac involvement takes a few weeks. Chorea is rare, but it happens. These kids' movements might be called tics, twitches, jerks, spasms, or even seizures. Like this young lady, they bob their heads and flick their hands. They can't drink from a cup, can't write their names, and may have trouble walking. The other 2 criteria are both quite rare, but highly specific for rheumatic fever. Erythema marginatum may be difficult to see, spreads outwards, and is not itchy. Nodules, if present, are painless and mobile. The minor criteria provide supporting evidence. Fever, high inflammatory markers, and prolonged PR interval all help make the diagnosis. Arthralgia without arthritis may also point to acute rheumatic fever. And of course, we need evidence of the bug that triggered it all in the first place, Group A Streptococcus. Upper limits of normal serology may be different to what your lab reports. So let's add up the criteria for our case. Say he has a swollen knee and ankle, that's one major criterion. Fever and a high CRP gives him 2 minor. positive serology, and he's over the line. Always err on the side of diagnosing rheumatic fever in a high-risk population, as presentations may be subtle, especially for recurrences. So what do we do? Prevent by treating sore throats and impetigo early. Recognise the disease, treat newly diagnosed kids with penicillin and regular non-steroidals. Notify your public health service and refer on. But most importantly, tell the parents what's happening, tell the kids themselves what's happening, and especially tell the teenagers. Give them a handout and repeat it again at the next visit. Kids with rheumatic fever need 4 weekly benzathine penicillin injections until they're 21 years old, or at least 10 years. They need the injections when they're well, when they're sick, when they're on a footy trip, when they're pregnant, when they go to university, every month until they're 21. It's your job to help that happen. The Australian Rheumatic Heart Disease website has great resources, including e-learning modules and the guideline that was a primary source for this talk. There's even an app, so no excuses. Rheumatic fever is not a medical history footnote. It exists today. It ruptures kids' valves, threatens their lives, and causes lifelong heart damage. It's preventable and treatable, but it first needs to be recognised. Don't forget rheumatic fever. Let's try to keep up with the Joneses.